Next, I want to move on to the first session, which is on early diagnosis tales from the esophagus. The moderator for this session is Dr. Vish Nair, who was Sam's trainee and currently associate professor at the Fred Hutchinson's Cancer Center. Visham?
Thank you, Joe. Good morning, everybody. My name is Vish Nair. Before I introduce our next speaker, I'd like to provide some context. Like Joe alluded to, my relationship with Sam. I trained in pulmonary critical care medicine here at Stanford from 2007 to 2011, and then joined Sam's group because I was interested in imaging molecular biomarkers for detecting lung cancer. Over the next 6 years, I worked with him on building a blood-based biorepository of lung cancer patients and developing lung cancer diagnostics using a series of novel molecular assays, many of which were Stanford-based. Through this, Sam was and remains the formative influence in how I think about cancer early detection today. My academic success to date is in large part due to him. Thank you, Sam. Next, it's a pleasure and honor to introduce Dr. Rebecca Fitzgerald, a professor of cancer prevention at the University of Cambridge and a practicing cancer consultant in Britain's National Health Service. She is a specialist in cancer of the esophagus who has won multiple prestigious awards, including the Westminster Medal, Jane Wardle, and Don Listman prizes for developing a new diagnostic method known as a cytosponge. She has also been elected a fellow of the British Academy of Medical Sciences and is a member of the European Molecular Biology Organization, EMBO. Rebecca jointly chaired the recent evidence review report on cancer screening in Europe that was conducted by the Federation of European Academies of Medicine to inform the European Commission. She has published nearly 300 times and in multiple journals of the Nature series recently. Notably, she was part of a white paper on the early detection of cancer with Sam, published posthumously this year in Science. Professor Fitzgerald, welcome.
Thank you so much. Thank you for the introduction, and a real pleasure to be here and to be invited to present at this wonderful symposium. Real pleasure to be here, and I had a pleasure also of being in the inaugural international ACE consortium for early detection between Stanford, Canary Center, Oregon Health Sciences University, Cambridge, Manchester, and UCL, and sat with Sam as we really got liftoff for that consortium to think about how across our organizations we could move the bar for early diagnosis. But today I'm going to talk to you about my own work from the esophagus, which really builds on what we were just hearing about in terms of the importance of keeping it simple for early diagnosis, making it in a cost efficient so that we can really scale up what we're trying to do for population-wide strategies. I'm going to be talking specifically about Cytosponge, which is the technology I've developed and licensed out. So esophageal cancer is unfortunately a really deadly disease that tends to present at a symptomatic advanced stage, usually when there's already metastases, and the 5-year survival is less than 20%. So the vision here is to develop an ideal screening program whereby we identify the individuals at high risk and then perform a very simple triage test to identify those with early cancer that we can then treat. And this is really a sort of practical proposition because we have fantastic treatments now, endoscopic therapies for patients that present with early disease. So whereas we need multimodal therapy, often with poor outcomes for advanced disease, when it's detected early, we can usually remove this with endoscopic resection or ablation with fantastic 5-year survival. So if we've got such good treatments, we then need to go out and find these people who've got early disease. And what do we need to do to really develop these new early detection approaches? This is the paper that was alluded to in the introduction, a paper written in memory of Sam, in which we really go through the challenges stepwise to develop new early detection approaches, starting with understanding the biology and prognosis of early cancer, identifying the at-risk group, finding and validating cancer detection biomarkers, then moving to the technology itself to develop accurate technologies for early detection, and then to evaluate them on the intended population. And as we'll all be aware, many biomarkers kind of stop somewhere along this diagram, and often they're not fully evaluated in the intended population, and they never make it out to implementation. So Barrett's esophagus is the precursor lesion for esophageal adenocarcinoma, but actually it's not been really clear whether all esophageal adenocarcinoma starts with Barrett. So before we really get to what the technology is, going back to the diagram in the science paper, it's important to understand the biology. So the first question is, is Barrett's the gatekeeper for esophageal adenocarcinoma? And recently, to really look at this question in new detail, we took a multi-faceted approach, including single-cell sequencing, lineage tracing with the somatic mutations and ATAC sequencing, and organoid models to really ask, what is the cell of origin for Barrett's esophagus, and is that the gatekeeper to esophageal adenocarcinoma? And to cut a long story short, what we found was that Barrett's does seem to be the obligate precursor. There is no difference to the transcriptome of esophageal adenocarcinomas that present with a large tumor when you can no longer see the Barrett's. The Barrett's has probably been overgrown. Furthermore, in this computational modeling study, this is done by Kit Curtis and colleagues in San Diego, they provided a multi-scale model which then maps perfectly to the SEER incidence data when you consider Barrett's as the precursor stage, again suggesting that Barrett's is the transition point to this cancer type. So both of those studies would suggest that we should go out looking for Barrett's esophagus in individuals at risk. Now, epidemiologically, esophageal adenocarcinoma is relatively rare, and it's very geographically patchy. We don't want to be screening everybody in low-risk areas or those at low risk themselves. We want to identify that high-risk population first to really make this a tractable, affordable proposition. And a key risk factor is acid and bile reflux. And therefore, patients with reflux are often on heartburn medication, which is very useful as a gateway to identify the individuals at risk. There are various risk scores. This is one called the Kunzman model, which seems to be one of the better validated, which takes into account the fact that older age, male sex are also risk factors, being overweight with a higher body mass index, smoking, and a known esophageal condition such as inflammation, etc. These are all risk factors. But for most of our studies, we took a very pragmatic view, which was age over 50. We recruited men and women, but we used medication for reflux as a real way of identifying those people at high risk. So how are we going to investigate these individuals at risk? So endoscopy would be the gold standard, but referral for endoscopy to investigate heartburn, to screen for Barrett's esophagus, is really probably not feasible on a population scale. Furthermore, the people at risk probably aren't going to come to medical attention. It's not going to be accessible and equal access. It's a barrier. So can we find a much more minimally invasive, straightforward approach? Now, there are many technologies being developed, which include breath testing, blood biomarkers, which get very challenging when we're looking at precancerous conditions or non-endoscopic imaging. The route we took was a very low-cost, simple approach by which we developed a test that could provide a non-endoscopic sample, a pan-esophageal sample, with a really high number of cells that then one could interrogate in the lab using assays to identify whether you've got Barrett's esophagus, and furthermore, whether there are cells suggesting that you're progressing to cancer. So this is the cell collection device which we developed. It's a very simple capsule which you swallow with some water. As that reaches the stomach, the capsule will dissolve, and out pops this compressed sponge, which has been compressed prior to this within that capsule. This is usually administered by a nurse who then simply retrieves it over a few seconds, collecting a myriad of cells from the top of the stomach, the gastric cardia, and along the whole length of the esophagus. And these clumps of cells are then collected in this mesh for analysis, and you get upward of 1 million cells, often as many as 4 million cells that you can send to the lab. Now we process this to a sort of digital pathology specimen. You get a lot of added value by looking at the pathology slide, but you might ask, how is this scalable? And how do you identify these precursor Barrett cells other than by morphology? And so this is a biomarker that we developed called trephine factor 3, which is a simple protein assay, which highlights the goblet cells, which are pathognomic of Barrett's esophagus. And because this is a simple immunostain, you can then use AI-assisted triage to identify them and further quantify them You can also perform quality control using this AI-assisted triage to ensure that the capsule reached the stomach. And this is read out as a sort of confidence estimation for the pathologist, who can be directed right to the area of concern on the slide and be given an indication by the colour hotspot as to whether it's likely to contain these pathognomic goblet cells of Barrett's esophagus and be TFF3 positive or not. And this means that these rather large sample that is collected by the Cytosponge can be read in a few seconds. So what's the evidence that this technique is useful? So we have gone through a very careful stepwise series of discovery and validation studies, starting from preclinical exploratory studies through to clinical grade assay development and verification, longitudinal trials, and then a prospective randomized trial. So I'm not going to go through these in detail, but again, important to note that we have looked at the intended screening population, starting with our early study in 2011, to really understand how it performs in the place where it's intended. We performed a large case control study of over 1,000 patients to look at the performance characteristics in terms of specificity and sensitivity, with very encouraging results that led us to go on and do a randomized control trial. So the randomized control trial compared screening with Cytosponge to family practice usual care, with the main endpoint saying, if you offered this test to individuals at risk, do you diagnose more Barrett's compared to the usual care? And this shows you the headline of results. So we randomized, this was in family practices, over 13,000 patients. They were all on medication for their reflux. And this is an intention to treat analysis comparing all of those offered Cytosponge TFF3 to usual care. And you'll see that the number of Barrett's diagnosed in usual care was 13 compared to 140 in the Cytosponge arm, so a rate ratio of over 10. Now, what was the uptake of Cytosponge? 39% expressed interest and 24% participated. And you have to bear in mind that these people just received a letter out of the blue inviting them to take part, which is always a challenge to get people to take part in these research studies. Even with that 24% participation, because this is intention to treat analysis, we found 10 times more Barrett's. So if, as this was rolled out, we could increase participation further through education and so on, then there's a lot of Barrett's out there to be found, and this rate ratio would likely increase even further. 13% then had a positive result and were referred on for endoscopy. And as well as finding Barrett's esophagus, we found patients with early cancer and dysplasia who went on and had curative treatment. So you might say, that's fine, you're finding the Barrett's, but does all Barrett's progress to cancer? Because actually that's a low rate of progression overall from non-dysplastic Barrett's through to dysplasia and cancer. And these are the sort of a summary graphic of the abnormalities you find in that progression series through dysplasia to cancer. It's a very heterogeneous cancer type, and if you start looking at the mutational landscape, it's actually quite difficult to really pick out which will progress versus those that have indolent disease. But we know a key trigger for progression to Barrett's esophagus is loss of P53, which is usually biallelic. So this was a study looking at the key copy number changes, comparing patients who didn't progress, comparing patients who do progress. You can see straight away the large number of abnormalities in the progressors compared to non-progressors. As I say, this pivotal point, which I hope you can see with my pointer, with the loss of P53. And of course, P53 can be easily ascertained with aberrant immunostaining on immunohistochemistry to fit it into our digital pathology algorithm. So this is a summary of a very large retrospective study we did to see if we could pick out the high-risk Barrett's from the low-risk Barrett's. And using this simple panel, we were able to determine patients into low, moderate, and high risk. And the sensitivity for our panel for distinguishing moderate and high risk from low risk was 94%. So we've been able to roll this out prospectively to not only identify Barrett's with the TFF3, but also those who likely need more careful follow-up because they may be progressing. And actually, COVID-19 has been a bit of an opportunity for us to implement Cytosponge and gain real-world evidence when endoscopy was really shut down for a period. And in the UK, they looked to us to see if we could help recover some activity, diagnostic activity for patients with reflux symptoms and patients with Barrett's undergoing surveillance. And we've now done over 10,000 Cytosponge tests with excellent results, not only in terms of the performance, but the health economics and the acceptability. And the new American College guidelines just published suggests that a swallowable non-endoscopic capsule sponge combined with a biomarker is an acceptable alternative to endoscopy for screening for Barrett's in those with chronic reflux symptoms and other factors, risk factors. But is that evidence enough? So it's always an important question to ask as to what the burden of evidence needs to go out and do proactive screening on a population level. And in the UK, it's felt that we really need a randomized trial to look at mortality endpoints. So this is now funded. This trial will start next year, randomized 2-to-1, usual care to Cytosponge TFF3, again in that at-risk population with reflux symptoms, to see if this Cytosponge will not only diagnose more cases of Barrett's, but also reduce mortality from esophageal adenocarcinoma. And within this screening trial, we'll also have a surveillance trial embedded. So what we are aiming to do with our research is move towards a new precision era for screening and surveillance for esophageal adenocarcinoma, in which we take the population at risk, we identify those at the highest risk who need some form of screening. We then perform a non-endoscopic triage test for Barrett's esophagus, and if that's positive, put them into non-endoscopic surveillance, performing risk stratification with biomarkers, which are straightforward and easy to read out from. That will then enable us to really focus in on those patients at greatest risk who need much more detailed imaging and mapping and endoscopic therapy. And so just to conclude, this is our standard kind of endoscopic image where we use white light endoscopy and multiple biopsies to find early lesions, which can be rather like looking for a needle in a haystack. These are white light, high resolution images, which all show patients with early cancer dysplasia. Some of them you may be able to spot the abnormality, but in many of them it's really very challenging. And so I think there's a lot of work to be done, as well as having our simple, inexpensive, non-endoscopic tools like Cytosponge, to then on the high-risk patients focus in great detail using state-of-the-art imaging to identify the early lesions. This is one such example of spectral endoscopy being developed by Sarah Bondic, who was a postdoc with Sam, now based in Cambridge, in which using these spectral endoscopes for a proof of principle study in Barrett's esophagus, in a spectral unmixing deep learning and image simulation can be used to pick out areas of high risk. So I think this is the vision for the future, a wide funnel going down to state-of-the-art imaging, but using low-cost triage on the way to do so. And with that, to really hope to try and improve what is currently really terrible outcomes for this disease. So very happy to take questions. I hope that's given you some insight into the work we've been doing. I'd like to thank my fantastic group in Cambridge, past and present members, our funders and collaborators. Thank you very much.
Thank you, Dr. Fitzgerald. Fascinating talk. Questions from the audience, please go ahead and submit them online. And while we're waiting for some to come in, I have a question. I'm a pulmonologist and we do bronchoscopy quite a bit. And I've done some work with Max Dean and there's others who have shown this at different tissue levels, that there's field cancerization in the lung. And it can kind of make the baseline genome to call cancer-derived mutations fairly messy. How are you handling that with Cytosponge? Is that playing a confounding role in terms of being able to differentiate Barrett's from normal histological tissue that is harboring mutations? I'm just curious about your thoughts on that.
Yeah, I mean, so as I described, the approach we've taken is to use protein expression markers, phenotypic changes, actually, rather than go for the mutational landscape. The mutational landscape is enormously heterogeneous, aside from P53. And P53 you can measure, of course, by DNA sequencing. We've done that on Cytosponge, but actually the immunoprofile readout is a very simple way of getting at the P53 status in our hands. So yes, you might think mutations would be one way to go, but very heterogeneous, quite difficult to interpret. And actually, for something which is applicable on a mass screening scale, we find that the digital pathology coupled with AI actually works really well. And we can get added value as well. You can also find other abnormalities in the esophagus at the same time, which can include inflammation, ulceration, eosinophilic esophagitis. And I haven't talked about squamous cell carcinoma, which is the most common esophageal cancer globally. And you can use an exactly analogous approach for detecting early squamous cell carcinoma of the esophagus, again by digital pathology coupled with immunomarkers perspective.
Okay, we just had a question that came in. What do you foresee as the main roadblocks now to achieving widespread adoption of the Cytosponge?
Yeah, I mean, never underestimate implementation and adoption research. I think it's easy to think you've done a lot of the hard work when you've done big trials and you've done a randomized trial of 13,000 patients. You know, that seems quite a big step. But as I mentioned, the uptake in our trial was 24%. Some of that was logistics around people being able to attend a research appointment. But all of that's around education and awareness. And for any new technology, you need education and awareness not only amongst the individuals, the public, which is very important, but also in terms of the clinicians. As clinicians, we get very wedded to the things we've been used to, the things we've been brought up with. This is complementary to endoscopy. It's not going to replace endoscopy, but you're never going to endoscope a lot of the people who really need it. So I think a lot of it's about education and awareness then. As I say, and then getting it in the guidelines and getting the policy adopters to take it up as well.
Mm-hmm. Maybe I can follow that question up with cost. I know the National Health Service and Medicare, they're very different entities, obviously, in different countries. But could you comment a little bit on the cost of implementation? It seems like it's a very practical, fairly cost-effective method.
Yeah, so this is less than half of the cost of an endoscopy, depending which healthcare system you're in. And the rewards in our healthcare systems are different, of course. So in the NHS, we're not rewarded for doing endoscopy in quite the same way as you are in the private healthcare system. So that definitely is potentially a barrier to uptake in the US. In the healthcare system, endoscopy supply and demand is an issue. So there are big bottlenecks and waiting lists for endoscopy, as well as the cost. And I think increasingly the pandemic's made us realize how important it is to make healthcare much more accessible, easy for people to get to try and avoid bringing everyone into the hospital when it's not really required. And this is a test that can be done in an office setting. So I think that's another important aspect.
Right. Any other questions for Professor Fitzgerald? There's one that came in just now. Have you studied attempts to prevent progression of disease, such as dietary changes, and use Cytosponge to monitor those changes serially? Yeah.
So we've now got patients who are having multiple surveillance endoscopies. That hasn't been coupled with a prevention intervention, but that could be done. For Barrett's esophagus, actually our treatments for dysplasia now are excellent. So we tend to intervene quite early anyway. So, there's a lot of discussion in the field about whether there's still a role for prevention strategies. There was a large trial using aspirin, for example, coupled with high and low dose proton pump inhibitor therapy. So that's something that can be thought about, other lifestyle interventions like stopping smoking, losing weight, etc. Where this technology really has been shown to be useful for monitoring and intervention is in the context actually not of cancer, but of eosinophilic esophagitis, where these patients have terrible inflammation of the esophagus, which can lead to stricturing. And often there are dietary interventions. And these patients have to have repeated, really regular endoscopies, which are quite challenging for people. And there the Cytosponge has been really useful as a monitoring patients undergoing various elimination diets. But we're keen actually in the Best 4 screening trial, this huge screening trial, which is going to be 120,000 patients, to see if we can couple some of the work we're doing with the opportunity for lifestyle interventions. So, and I think it's always important to think about in any kind of screening setting what you can do to be educating people, helping to reduce risks and improve long-term outcomes alongside the screening. Yeah.
Wonderful. Well, thank you again, Professor Fitzgerald. I know it's the end of the day there, so appreciate you getting on.
Pleasure. Thank you for having me.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.